crystalloids, and there's two types, and that's where one of the big points of debate is right now in the world of fluids. Normal saline is a traditional fluid, but as you can see, what happens is as you administer this over time, you increase your chloride concentration, but slowly cause an imbalance in bicarbonate and cause a hyperchloremic metabolic acidosis. So there's more interest in balanced fluids, and these include lactated ringers, in which the buffer lactate replaces a lot of the chlorine, and plasmolite, where there's more of a mix of different types of buffers. Now, this isn't happening in a vacuum. There's a lot of discussion in the ICU world. There's a lot of New England Journal papers in the last 5 years, split, salt, basics, plus, all looking at this question. And the thought is that the acidosis related to high doses of saline may cause renal vasoconstriction and renal injury and potentially impact clinical course. And so two of the largest studies have shown benefit. Three of the smaller ones didn't show benefit. So the jury is really still out on this. You may favor, again, balanced crystalloids like LR, but I think it's going to take large numbers and a little more work to definitively answer this. Now, pancreatitis is a special case because of a few other features. It's well known that diabetic ketoacidosis and organic acidemia are associated with pancreatitis. It's also known that as you drop the pH, there's intensified cellular calcium signaling, which happens at the membranes, but also you can see in models that there's more trypsin activation as well as the pH drops. And as you know, normal saline has a pH of 5, LR has a pH of 6.5, and it affects the body in that way. So it's even of greater interest. The other thing is there is an immune component to this. Lactate ringers does contain a fairly large amount of lactate, and at least in animal models, it appears that it stimulates an anti-inflammatory panel of cytokines. And if you look at different animal models, beautifully summarized earlier, it does appear that lactate reduces pancreatitis injury, and it does this by stimulating the G1 protein coupled receptor 81. So there's been a couple of preclinical single center randomized trials. Beach and Wu did the first really nice one showing a significant reduction in SIRS with LR compared to NS. There's been several more. My group did one a few years ago in 120 patients, and we Beechin saw a big reduction in SIRS, which we didn't see, but we did see less ICU admission. We saw a shorter length of hospitalization and trends towards less necrosis. And when these are that thing's a little sticky. When these are all put together in meta-analysis, there does appear to be less moderate severe pancreatitis with LR compared to NS. There appears to be less local complications, and there appears to be less pancreatic necrosis. However, this is, again, a meta-analysis. So Enrique Dimodaro is nice enough to invite me along again on the steering committee. And we started a new study called the Waterland Trial. So we've enrolled 11 patients as of July 14th. It's underway in multiple centers. Many are in Spain, a few in India, Mexico, and then a couple in the US, including our center. And this was formerly called Galadriel when we applied for a grant for this in Europe, but now it's Waterland. So you may hear more about this. And it uses the arm of the Waterfall study, which we published last year. And so it's a moderate amount of fluid, and the primary endpoint is moderate and severe pancreatitis, but we're also looking carefully for markers of fluid overload and kidney injury related to fluid type. In the anticipation that there's going to be a 10% reduction in moderate and severe pancreatitis with LR as opposed to NS based on our meta-analysis. So we're aiming for 720 patients. There's no planned interim analysis on this one, so it's going to go forward to 720. So I think that summarizes the state of the first big debate. Do you give NS or do you give LR? Or you give plasmolite? I don't think we know. I think Waterland's going to help. I think there's going to be a lot more information on this, though, also coming from the ICU and critical care world. So on to fluid volume. That's the other big question in pancreatitis. So very nice animal models have shown that the intensity of pancreatitis does correlate with regional hypoperfusion, and this can be corrected at least with the fluids and in terms of oxygen tension and histology. And also with these animal models, a lot of these were done at San Francisco General in the 1980s. They showed their increased survival with increased peritoneal fluid nutrition. Now, in terms of applying this to human studies, the most of the initial data was from cohort type work. Tim Gard has some classic classic findings, if you give more of the fluid up front, then the patients tend to do better over a 72-hour period in terms of necrosis and survival. Also, Beechin and many people in this room have shown that when you have markers of heme concentration, like elevated hematocrit, increasing creatinine, increasing BUN, these things are associated with adverse clinical course, as well as renal insufficiency and higher mortality, but they're not super sensitive. So they have a good negative predictive value in this area. So all this kind of points to the idea that ample fluid might be more helpful. We did a small pilot in fairly healthy patients with a composite endpoint, looking at tolerance to oral nutrition and improvement in labs, and found that there appeared to be a better outcome with a more aggressive strategy, and laid out a way of doing these trials in terms of checkpoints and volumes. There was interesting work though coming from China and other places that with very high fluid dose there may be more adverse events. This was very, very high rates. You can see here, 1,000 cc's per hour, and they did have more a requirement for ventilator support. There was decreased survival. So again, I was lucky enough to be invited by Enrique to work on the waterfall trial. This one came out last year, and it was an 18-center study, and we were looking at the basically kind of modeled on our earlier study of mild pancreatitis, if either aggressive or moderate arms. So we set these at, you basically got a bolus at 20 cc's per kilo per hour, and then it was followed by a high rate of 3 cc's per kilo per hour in the aggressive arm. In the moderate arm, we gave 10 cc's per kilo for people that were volume down, but otherwise just went straight to a rate of 1.5, and then phase these into fairly early oral hydration strategy. And the main endpoint was moderately severe and severe pancreatitis. The secondary endpoint was adverse events. And so this one was actually stopped at an interim analysis. And the reason is that there was a significant increase in fluid overload. You can see at the bottom in the aggressive arm, 20 versus 6%, and even more moderate severe overload. But what's interesting, what I found even more interesting is that there was really no improvement. Again, this was underpowered for that outcome because it was stopped in an interim analysis, but there was actually trends towards more ICU admission, even a little bit more trend towards more necrosis, and the trend towards more respiratory failure for those that got this very aggressive strategy. So I was a big believer in the aggressive strategy before, so this is really shocking and really kind of changed my focus a little bit. And the thing about it was that the over hydration we saw wasn't really mild either. Most of the patients did require diuretics, a few required inotropes, very few were corrected by just decreasing hydration. So what we really found was that aggressive hydration in unselected patients wasn't helpful in terms of reducing moderate and severe pancreatitis, and that there ended up being more problems with ICU admission, fluid overload, and respiratory failure. So I think the big takeaway is that aggressive fluids aren't a real blunt sword to treat acute pancreatitis, like at least a lot of people, including myself, had thought before this trial. And this is also not happening in a vacuum. There's been about 10 studies in New England Journal in the last 5 years looking at this whole debate of aggressive hydration in general for people, mostly with sepsis, but really any kind of ICU or fairly severe ER type problem. And it's a similar pathway. Rivers et al. In Detroit first demonstrated the idea of early goal-directed therapy for hypotension due to sepsis, but with a really interesting study first in Africa, looking at children who were being either resuscitated aggressively or treated in a more moderate fashion. They actually found that there was more mortality with this really aggressive strategy. And then there's three New England Journal trials, but here and in Europe, looking at this strategy for sepsis, and actually in all three there was no improvement. And a patient level meta-analysis actually showed that there was higher cost, higher ICU stay, but no difference in mortality. And very recently, Classic and Clovers, which are two large multicenter trials, show that there's no real difference in either a restrictive versus a liberal or standard fluid resuscitation strategy for ICU patients who with sepsis or refractory. So what we found was similar to what's being seen in the sepsis and ICU literature. So there were some controversies, though. There was a large bolus in aggressive arm, even without baseline hypovolemia. So one would question whether that would really be done in clinical practice. Also, it may underestimate the benefit in more severe patients who might be fluid refractory and actually may need a lot more fluids. The control group of Waterfall only had about 7% had necrosis versus the bigger studies of predicted severe pancreatitis go anywhere from 16 to 62% with necrosis. Also use physical exam rather than looking at a lot of more objective measures like ultrasound measurements. And but overall, I think what the message that came out of that is that the next step is probably to look at a more nuanced approach to resuscitation based on volume status. So there's interesting models that John Windsor and others have kind of helped me with and talked me through. And there's the 3-compartment model looking at intervascular, interstitial, intercellular spaces, and then 4 phases of resuscitation. So the first is really the rescue resuscitation phase. And this is when people have low intervascular volume, they're hypotensive. And this one's fairly straightforward. You really do have to resuscitate these folks relatively quickly. And with the real challenge in pancreatitis is the optimization phase. This is where you moderate the fluids to maintain good organ perfusion. And this is more challenging because there's interstitial edema developing. And now that you have better flow in the vasculature, there's more issues with backflow. And so it's harder to get the fluid out of the interstitium. And the other nuance here is that there's really capillary leak happening. So capillary leak has been described for sepsis, Clarkson's as idiopathic, ricin poisoning, and then really Dr. Whitcomb's group really nicely showed that with trajectory analysis of albumin not long ago that it certainly is happening in pancreatitis as well, although not fully recognized by the renal community yet. But basically there's a leak into the interstitium from the capillaries. And the key point on this is that once you've reached this point and you're leaking, if you resuscitate more, you worsen extremity edema, lung edema, gut edema, but it may improve issues with kidney injury. So you kind of trade the kidney for the other organs. It depends how you go with it as you keep hydrating in a capillary leak situation, but something to increasingly recognize. So how to optimize resuscitation? So in waterfall and the sepsis literature, particularly in the pancreatitis literature, we haven't had the greatest measures. We use BUN or SIRS or serial vital signs. So it's hard to really do this really fine-tuned type of thing. There's pulse pressure variation, but the patient really has to be intubated for that to work well. You can use CVPs, but you do have to have a large central line in the patient. There is newer, less invasive technology coming though. So this is called the flow track by Edwards. I don't work, no disclosures or anything like that, but basically it hooks up to an art line and it can give you a stroke volume, which that actually can use fairly nicely to titrate fluids. Passive leg raises do mimic a 300 milliliter fluid challenge. And just want to highlight this nice study from really kind of inspired by John Windsor recently in pancreatology, where they basically took patients and they compared the passive leg raise and they checked the stroke volume using this flow track system with the radial art line. They compared it to a kind of detailed clinical assessment. And they found that actually the stroke volume changes with the leg raises was much more accurate to predict responses to many fluid challenges, suggesting they better predict who needs that more nuanced fluid strategy. To future directions, I think this type of nuanced work will need larger multi-center clinical trials. A nice thing is there's now this sort of clear vision thing coming. We're actually with more of like what looks like an O2 sat monitor. You can measure a stroke volume now without any invasion in terms of having down an arterial line or other type of invasive monitoring. So this thing will really support this idea of really detailed, nice fluid studies using more objective criterion. Also, again, from Dr. Whitcomb's team is these very detailed tools. So that the aerial dynamic acute pancreatitis adapt tool is an algorithm that uses a lot of different data and scoring systems to offer recommendations for fluid therapy. We did a little pilot at our center. We had about 1,000 patients with acute pancreatitis, and we looked at the aerial recommendation versus patients who went way above the aerial, which can happen in a place where we give a lot of fluid. The outcomes were much better in terms of moderate severe pancreatitis, severe and nuanced renal failure with patients who were within the aerial recommendations and the non-aerial. So in a sense, it's kind of the beginning of artificial intelligence to guide clinical pancreatology. So in conclusion, fluid type, lactated ringers and other balanced fluids patients are less likely to develop a acidosis, normal saline. There's maybe a small difference seen in the sepsis community, although it's not definite. Pancreatitis considerations don't have some specific things. There is the higher pH favoring in terms of the acid-based chemistry with less acidosis favors less activation. Lactate may have an anti-inflammatory effect, and small randomized trials are showing a favorable benefit. However, the multi-center Waterland trial is now going around the world, so I think it'll help answer it. With fluid volume, the animal models show that regional hyperperfusion correlates with necrosis, and there's a lot of circumstantial evidence to give ample fluids, but the waterfall trial suggests that really aggressive fluids isn't really the solution for all comers with all types of pancreatitis. And really this nuanced approach with objective measurements with things like stroke volume at bedside or using very detailed machine learning systems like the ADAPT are likely to lead to a better outcome. Thank you for your time.
Thank you, Dr. Buxbaum, for a great overview. We'll take the questions to the end. And it's my great pleasure to introduce the next speaker, Dr. Ajit Sirivardena. He is a professor of hepatobiliary and pancreatic surgery from the University of Manchester. He will be presenting the best of the best from the Pancreas Club. The title of his presentation is "A Pro-calcitonin-based algorithm reduces antibiotic use in patients with acute pancreatitis. The final results of the Pro-cap randomized control trial."
So good morning. Thank you very much for that introduction. I'd like to start by thanking the organizers of Pancreas Fest for the invitation and the opportunity for us to come all the way to Pittsburgh to present these data. It's a real honor for us, and I'm very excited to be here with you with this distinguished audience. This is my disclosure slide. So the World Health Organization declared that antibiotic overuse and the resultant emergence of multi-resistant organisms is one of the existential threats facing mankind in the 21st century. If we bring that down to acute pancreatitis, the conventional sort of paradigm of acute pancreatitis is of an early phase, which is systemic inflammation, and a later phase, which is characterized by the emergence of infected necrosis and infective organisms. This is very common in textbooks, but this is probably an oversimplification. And one of our early randomized trials back in the start of this century, when we were looking at early enteral nutrition, turns out early enteral nutrition doesn't really make a difference. These studies, there's a group of these, debunked the theory that you need to be strictly nil by mouth. But in this study, one of the things we looked at was whether early enteral nutrition modified the disease course of acute pancreatitis. And the solid line here is those patients receiving early enteral nutrition, and you'll see that it made no difference. But what was interesting is that in this study, we also looked at gut permeability, measuring differential absorption of high and low molecular weight sugars. And I was really too young to appreciate what I had here, but this study showed that even at the time of admission to hospital, many patients had abnormal gut permeability early on in the course of their acute pancreatitis. So this rather simplistic paradigm should probably be modified to a slightly more nuanced interpretation, which is that even in the early phase, there's evidence of altered gut permeability, a modified gut microbiome, and activation of enteral-sourced immune inflammatory mediators. But this isn't infection. So the IAP-APA evidence-based guidelines, which are still 10 years on, still very good, the statement here that intravenous antibiotic prophylaxis is not recommended for the prevention of infectious complications in acute pancreatitis. This statement still holds true today. NCPOD, which is a non-governmental organization in the UK who do national surveys, they did a national survey of some 600 or 700 patients with acute pancreatitis. And this is from their press release for the BBC. And they said that a particularly worrying aspect of the report was that over 60% of patients in this study were prescribed antibiotics, despite the guideline evidence saying don't use antibiotics. So we looked at this. This is not a phenomenon that is restricted to the UK. It's a global phenomenon. Similar cohorts from the USA, Germany, South Africa, India, Australia, and also John Windsor's group in New Zealand have shown that antibiotic use is somewhere between 60 to 70% of all patients admitted to hospital with acute pancreatitis, possibly in some centers as high as 80 to 85%. So antibiotic overuse is a global phenomenon in patients with acute pancreatitis because of the difficulty in differentiating a systemic inflammatory response from the presence of infection. So one way in which you could potentially address this is by pro-calcitonin measurement. So pro-calcitonin, which the audience here will know, is the peptide precursor of calcitonin. It's produced in response to infection. So normal physiologic levels are low. They rise rapidly in the face of a bacterial toxin exposure, and they fall rapidly once bacteria have been eradicated. PCT measurement-based algorithms have been evaluated in a range of disease settings and are shown to be generally safe and are associated with reduced antibiotic use. So our hypothesis was that our study aimed to test the hypothesis that a pro-calcitonin-based algorithm to guide initiation, continuation, and discontinuation of antibiotics will lead to reduced antibiotic use in patients with acute pancreatitis, of course, without an adverse effect on outcome. So PROCAP is a patient-blinded, single-center, randomized controlled trial with the intervention being a pro-calcitonin measurement algorithm. Oops. Inclusion criteria were adult patients over 18 years with acute pancreatitis who were able to provide informed consent and who had 2 of the 3 standard Atlanta 2012 criteria, either clinical features of acute abdominal pain, raised enzyme levels, or imaging features of acute pancreatitis. So 2 of those 3. We excluded patients who were unable to provide informed consent, and we also excluded patients who had mandated prolonged antibiotic use, for example, patients who had undergone a prior splenectomy. Participants were randomly allocated on a 1-to-1 basis to intervention or control, and with this kind of trial, to try and keep the patient populations fairly equivalent, we had 2 stratification variables. The first was by disease severity, mild versus moderate and severe, so that there wasn't a cluster of patients with severe disease in one or other arm. And the second was by admission pathway. So our hospital, as is the same in this country, is one of the big centers in our conurbation that deals with patients with severe acute pancreatitis. So we also had a stratification variable by admission pathway, either direct from the emergency room in our hospital or tertiary transfers, who are the sickest patients with acute pancreatitis, typically transferred 20, 30 days in after treatment in an ICU or a surgical ward elsewhere. So this schema shows the trial. The block over on the left side is the intervention arm. The other one is the control. So both arms, as you would expect, had standard care of acute pancreatitis as close as we could get to the IAP APA guidelines. In both arms, we permitted mandated antibiotic use. So in other words, if a patient had a positive microbiology result, you had mandated antibiotic use, that was fine. Also, prophylaxis for procedures, typically laparoscopic cholecystectomy or endoscopic intervention of necrosis. So the sole difference between control and intervention was empiric use of antibiotics. In other words, that situation that came about when patients are 2, 3, 4, 5 days into the hospital course, they look septic, the clinician wants to use antibiotics. In that situation, in patients in the intervention arm, we asked that you use this algorithm. I don't think this is going to project too well to the back of the room. So this, our hospital now uses the EPIC Hive EPR, but this predates that. So we had, this was laminated and placed in the chart in patients who were randomized to the intervention arm. And what we said was, we asked that if you were a patient randomized to the intervention arm, a clinician or a group of clinicians were thinking of using antibiotics, we asked that you measure the PCT. If it was less than 1, we said don't use antibiotics or stop antibiotics if patients are already on antibiotics. If you were still anxious about it, you could repeat it at 24 hours. If you were still anxious about it and wanted to override, all PCT algorithm studies do have a clinician safety-based override. And of course, you can override it, but we ask that you confirm that with an ITU or one of the HPB surgical attendings. The turnaround time in our hospital, according to the manufacturer, was 30 minutes from sample take to result. In reality, it's about 90 minutes to get the result back. So we ask that clinicians assess the patient, take a history, do basic resuscitation, and then make an antibiotic decision, rather than just turn up, prescribe meropenem, and go away. So it's important to share the statistical design. We use a superiority design. There's no point using an equivalence trial design for a new test. So if the new test is said to be better, you need to do a superiority design. We knew fairly accurately in the control population that about 60% of patients are exposed to antibiotics. So we had a good comparator and said about 20% absolute change was adjudged to be clinically important. And for that to should be shown with 90% power, we needed 260 patients in the trial, 130 in each arm, which also gave us a suitable secondary endpoint of mortality. So the primary outcome was antibiotic use at any point during the inpatient stay. Study was approved by appropriate regional ethics committees, and the protocol was published prior to commencement. Pro-calc was open to recruitment from 2018 to 2020 through the COVID pandemic. So the results: 369 patients were assessed, 260 were randomized, 132 to intervention, 128 to control. All those patients allocated to intervention or control had their results available for analysis at the end of the study. In terms of the population demographics, there was no difference between intervention and control in terms of gender, in terms of disease severity, or tertiary or direct admission pathway. There was no difference in terms of severity, and the etiology of the pancreatitis was a typical Northern European population of gallstone predominant disease with also alcohol and post-ERCP acute pancreatitis. So these are the key results. And you can see here that the use of a PCT algorithm resulted in a statistically significant reduction in antibiotic use in patients with acute pancreatitis. Once prophylactic use was excluded, that significant difference and the size of the intervention effect persisted. This resulted in a significant reduction in days of antibiotic use, which was a secondary outcome. There was no difference in all-cause mortality. There was a numerically higher incidence of clinical infection, but this was not statistically significant. We analyzed this subsequently for resistant organisms, incidence of infected necrosis, positive blood cultures, bacteremias, and there was no difference between intervention and control in any of those three areas. I was particularly interested in the subgroup who had severe acute pancreatitis, because in our hospital, these are patients who are transferred in 20, 30 days into the course of acute pancreatitis, often on 3 antibiotics and an antifungal. And even in that group of patients, the application of the PCT algorithm was, first of all, feasible, and second, resulted in a significant reduction in antibiotic use. So the odds ratio for the intervention effect is 0.49. It's important when you're looking at a study to understand its limitations. And the main limitation with this study is that it's a single center study. So there could theoretically be something at play in Manchester, which was not there elsewhere. And that's why the Buxbaum studies of multi-center studies is really the way to go. This was not one of those, but I have the privilege to be involved with the IHPBA's global outreach program, and I teach in Sri Lanka. I'm ethnically Sri Lankan, also in Myanmar and Nepal. And when I've been out to those places, the management of acute pancreatitis globally is pretty much the same. It's its diagnosis is fluid resuscitation. So given that pancreatitis management is relatively standard across healthcare systems, it's likely that these findings are going to be generalizable. So our findings suggest that pro-calcitonin guided care can reduce antibiotic use without increasing infection or harm in patients with acute pancreatitis. And PCT measurement should be considered in patients with acute pancreatitis, incorporated into clinical guidelines. It feels to us like this is an intervention whose time has come in acute pancreatitis. Thank you very much for your attention.
Dr. Sriwardena, thank you so much for your great talk. Please come and join us. Our next and last speaker of the session, there's no need for introduction. This is Dr. David Woodcock, who is from the University of Pittsburgh. He's local. And as Marcia mentioned, the founder of Pancreas Fest back in 2005. I think he's going to be talking.
Is it? Okay, I can continue that. Sorry about that. Dr. Sriwardena, thank you so much for your great talk. Our next and last speaker is Dr. David Whitcomb. Of course, there's no need to introduce him. He is the founder of Pancreas First back in 2005, and he's going to be talking to us about the need of cholecystectomy in the index admission of acute pancreatitis. Dr. Whitcomb.
Thank you, Dr. Pippa Christou, who taught me everything I know about acute pancreatitis. So this is an interesting concept. Do we need a cholecystectomy in the index admission for people with acute pancreatitis? So this is an interesting study that was done from Hopkins. It was a review of a big database. And basically what they were able to show, let's see if this is the pointer, is that if you followed the recommendations in getting a cholecystectomy with biliary pancreatitis, your overall risk of recurrence was much lower than if you did not follow the guidelines and did not get a cholecystectomy. This is acute pancreatitis, and the recurrence rate was 3% versus 13%. Interestingly, it also seemed to reduce the incidence of chronic pancreatitis, and we don't know exactly what the details of that are, but it's kind of a provocative thought. The question now is, what is the proper timing for cholecystectomy? And this is where an important study came out. This is the Poncho study that came from the Dutch pancreatitis group. And just a couple of things that were interesting is that about a third of the patients got a ERCP and sphincterotomy during the index admission before they were randomized to either a cholecystectomy during that admission or a delay. So there's 5 days to get them into the randomization study, and they either waited a month or did the cholecystectomy the next day. What they found was that there was a big difference in the rates of recurrent pancreatitis and other biliary problems in the patients that got the same admission cholecystectomy versus those that were delayed. So 17% versus 5%. This is recurrent acute pancreatitis, which is 9% versus 2% within 30 days. And the number of episodes of biliary colic was much higher in people that still had a gallbladder. The cost effectiveness of doing an immediate cholecystectomy was also evaluated. And what they determined is the same day admission reduced the risk of readmission for recurrent pancreatitis later, as noted, but the mean cost was favorable for patients that got an early cholecystectomy. And even if you recognize that most of the individuals that did not get an immediate cholecystectomy would not get acute pancreatitis, there was still a favorable financial benefit from having an early cholecystectomy. So this went a long way to answer this question. There was also a meta-analysis of all the randomized trials, which was published in 2019. It showed about the same thing, that in this case, 19% of individuals with cholecystectomy that was delayed versus 3% for early cholecystectomy, which is similar to the Poncho trial, and what you see is that there is a statistically significant favor of doing an early cholecystectomy. Now, the big question is, what about the people that don't have a honking gallstone in their biliary duct and they are idiopathic? They're not alcoholic and they're not obviously biliary. So what is the etiology of idiopathic? So there's a couple studies that were done. I'm going to highlight a couple of them. This is one from Alabama. Mel Wilcox was involved in this, a systematic review in 2015. And what they found was that microlithiasis and biliary sludge was common in idiopathic pancreatitis, especially when you use endoscopic ultrasound, which is much more sensitive for identifying this. And they believe that the biliary tract disease was about 41% in idiopathic pancreatitis. Dr. Wilcox's group also did a prospective study looking at patients for 10 years that had a systematic evaluation for idiopathic pancreatitis. They had over 200 patients that were involved. And what they found was that 46% had a identified etiology, most of which were biliary. And they also felt that if there was a negative careful EUS exam, there was very little recurrent acute pancreatitis. And so this seemed to be an important way of preventing recurrent acute pancreatitis is how do you find out people that are at risk for biliary disease where it doesn't show up on standard imaging. So should you do a cholecystectomy for idiopathic recurrent acute pancreatitis? And I'm going to go over the rationale, the evidence, and some of the problems. So this is a study that Chris Forsmark did back in 2005. And what they did with this review is looked at idiopathic pancreatitis, and there was a paragraph called empiric cholecystectomy. And what they noted is that the use of an empiric cholecystectomy is supported by high prevalence of occult microlithiasis, which means you can't see it, but it's there. And in patients with a high false negative rate of doing biliary crystal analysis. So we, in fact, started doing biliary crystal analysis at University of Pittsburgh, and we were finding lots of crystals. Me, being a basic scientist, did a control experiment where we looked at the slides with just saline on it, and we could see little crystals, which we realized was glass that was coming off of our slides. So that was a false positive. So they also suggested that gallstones and microlithiasis are present in 37 to 89%. Well, that's a huge range. It means we don't know what the heck is going on. Later, another review came out in 2018 by some of our friends from Minnesota, and they wrote about the role of laparoscopic cholecystectomy in IRAP. And they said that in clinical practice, empiric laparoscopic cholecystectomy has been done in patients with recurrent acute pancreatitis to treat presumptive microlithiasis not detected on conventional image. That is absolutely correct. Although this technology is commonly used, there is no evidence supporting its use. Shortly thereafter, an important study came out from the Dutch group again. This is a systematic review. And what they did is they looked at a group of studies in which they did cholecystectomy or not for idiopathic pancreatitis. And what they recognized, first of all, is there was a lot of heterogeneity. Many of them considered cholecystectomy on typical imaging. Some of them used ultrasound, others didn't. They didn't mention which modality they used, and there was no genetic testing that was done. So it was very important. Despite that, they found results that were almost identical to the studies of doing cholecystectomy for gallstones, in which cholecystectomy seemed to improve the outcome and reduce the rates of recurrent acute pancreatitis. So conservative management, which means no cholecystectomy, 35% RAP, 11% with early cholecystectomy had acute pancreatitis anyway. And what was interesting is you look at the details of this, among 144 patients with true idiopathic acute pancreatitis, these are ones that had careful endoscopic ultrasound, they still had many with recurrence. 11% in the cholecystectomy group, 39% in the other group. The point is that out of 100 people with a cholecystectomy for idiopathic pancreatitis, it's negative, 28% had benefit, 72% had an unnecessary cholecystectomy. What are we doing? They actually recognize that this is a major problem because we don't really have a good way of detecting occult gallstones and making rational decisions. And in their paper, they added an algorithm of how to take care of acute pancreatitis. So they're admitted, was it caused by ERCP? Then you know what it is. You do your evaluation, do they have high ALT or imaging? And if so, it's biliary. Then you go down here, do ultrasound, look at alcohol and other etiologies. And here is really what you do to follow up on patients that have idiopathic pancreatitis. Now, they do not actually recommend cholecystectomy, but they know that we don't know what to do. So who is getting the gallstones? Well, the risk of idiopathic is related to the risk of gallstones. Now, I put this down here as for me to remember what I was taught. The people at risk for gallstones have the 4 Fs. They're fat, fertile females in their 40s, but you can't say that anymore. So, we'll just put the 4 Fs. But that's how they taught 40 years ago. So this is an interesting study. This is obesity and the symptoms of gallstone using a genetic susceptibility. Interesting paper published in one of the AGA journals. And basically what they did is they took a couple of huge samples in which they had detailed data, and they did both the genetic risk scores and that was a male or female, their age, and their BMI. And they just broke it up into a couple of simple patterns. And what they saw was that with increasing BMI and increasing polygenic risk score, there was a marked increase in the risk or likelihood of gallstones. And I want you to remember these two because I'm going to come back to them briefly. So this is a GWAS. I had to show a GWAS. So this is a GWAS for gallstones, and you can see there's a couple genes that are just really dominant in causing most of the problem with gallstone development. So this group, Lynn, picked 6 different genetic variant, just 6 SNPs for their polygenic risk score. I'll note that at Aerial Precision Medicine, we're offering this as well. We use 850 because you can see there's a lot of nuance in here as well. And this has been worked out pretty well, but they just used 6. And what they showed is that comparing BMI, lowest, middle, and highest 3 levels, they were then able to split them up according to their polygenic risk score. So less than 1 standard deviation in the middle and greater than 1 standard deviation. This is all comers, but I want to focus on this because this is females. And what this shows is that if you are less than 25 kilograms per meter square, a low BMI, and have a low polygenic risk score, then your risk of getting gallstones is 334 per 100,000 patient years. If you are in the higher one, BMI greater than 30, and have a BMI that's in the top 15, 17%, then your the incidence is 2,000 per 100,000 patient years. So in 10 years, you're at very high risk. And so it actually worked out pretty clearly. So this is in men, reference rate 270 per 100,000. If you are at the highest risk for weight and polygenic risk score as a man, it increases your risk by 1.7. And that's shown here. But if you're a female, I'm going to show the same thing, but what I did is I fixed the actual scale that for women, you see that the score is enormously increased. And so since the majority of patients with biliary pancreatitis are women, we know from adding the BMI, the age, which isn't shown on this graph, and the polygenic risk score, who actually is at high risk for gallstones and who's at low risk. And the question then in the future is, can this additional information be used to stratify patients into high risk and low risk so that you can make a rational decision about whether or not to take out the gallbladder? So I'm going to combine the old and new concepts. And what we suggest is you should only do a cholecystectomy in patients that need it. It's like a new concept. So the acute pancreatitis, you make the diagnosis, you do the early management, then you come to prevention of recurrent acute pancreatitis. First thing you want to know, are gallstones detected? The answer is yes. Surgery or ERCP. If the patient's healthy, you take out the gallbladder. If they're too sick, you do ERCP or something else. If there's no gallstones detected, is it alcohol related? Or if it is, then they get counseling. Otherwise, a few other etiologies. If it's idiopathic, then you go back here and they get the gallbladder out. So that's what we all do. The question is, sometimes do we wait until they have their second or third attack, or is it done immediately if they're non-alcoholics? What we want to focus on is this question here: are we doing this correctly? What we suggest is that there may be a better way of doing this, and in the future, what we want to do is to do our assessment, but we want to add some calculations like in the ADAPT score and genetics to make sure that we manage the first account, and then we want to do the second one. In the prevention of recurrence, if it's detected, you get a gallstone. If it's not, you check the genetics and it tells you whether or not you're at risk for gallstones. If you are, you go here directly. If there's other genetic causes, you get that taken care of, and other causes can be identified as well. Everyone needs to be counseled on alcohol and smoking because it drives chronic pancreatitis, and then you do the follow-up. So in summary, or in conclusion, gallstones are common, especially in women. Cholecystectomy reduces biliary acute pancreatitis, and it should be considered at the index admission. EUS can identify microlithiasis. Cholecystectomy likely reduces RAP in patients with true idiopathic pancreatitis, but the majority of patients that get a cholecystectomy actually don't need it. Genetic analysis of risk might reduce the necessity of cholecystectomy by segregating the high and low risk individuals and identifying other causes of acute pancreatitis. Thank you for your attention.
Thank you, Dr. Whitcomb, for nicely tying up GWAS and cholecystectomy. Please join us, and we have time to take a few questions. Dr. Whitcomb, while people are getting ready to ask questions, my first question to you. So you have nicely shown the current algorithm, just shown the algorithm from the PICAS trial, and you showed what your vision for the who needs cholecystectomy is. The Mayo Group has nicely shown previously that if somebody has gallstones and LFT elevation, if you do cholecystectomy, risk of recurrent pancreatitis is only 9%. But if there is no gallstone or no LFT elevation, risk is up to 60%. So where do you think that the genetic testing and decision on cholecystectomy fits among the spectrum?
I don't really need the microphone. First of all, I want to commend you on your outstanding dress today. You look great.
He got used to be seeing in scrubs when I was a resident all the time. Yeah.
Yes, but
The tie also.
the
looks
black
correct.
suit, the purple tie looks great. I forgot the question. No, there's a lot of interesting data going on, and what we know is a lot of heterogeneity as well. Which institution you're at, how you got there, those kinds of things. What we're really trying to focus on is how do you provide guidance at the point of care. And I think that what we're going to be able to do is begin stratifying patients better. Not every institution has endoscopic ultrasound, and not every institution with endoscopic ultrasound have physicians that know how to use it correctly. And so although that is an important tool, the question is that is it widely available, and can that help? If they have obvious evidence of gallstone, if there's a smoking gun, then it's probably a high probability that you're going to benefit. And so I think that what we're trying to do is we're trying to use knowledge to direct decisions rather than traditional algorithms that came out of the previous century.
Hi, good morning. Suhail Hussain, great talks. So gallstones are common in obese women, and it's inferred, therefore, that that microlithiasis is also common in obese females. But what is the data for that? And I mean, is that a definitive fact?
Yeah, so I don't know what the incidence of microlithiasis is in women of various sizes, or men for that matter. The other problem, though, I just mentioned is that patients that are NPO get microlithiasis. And so you don't know that that's actually the cause of acute pancreatitis if they've been in the ICU on TPN. You know, it's just if they're not eating, that you end up getting some gallbladder sludge as well. So, you know, there's some uncertainty and some assumptions that are made, but what we do as physicians, we go with the best probability and go from there. So the question about microlithiasis and whether or not that causes gallstone pancreatitis, I think has not been answered yet. But I think that stratifying patients as being high risk and low risk does have value in assessing the probability that individual person is going to have gallstone pancreatitis and therefore benefit from a cholecystectomy.
David, Steve Hughes, Florida, one of my favorite subjects. I'm going to change it just subtly. What about the patient that carries the diagnosis of alcoholic pancreatitis and a diagnosis of gallstones on ultrasound?
Wow, that was a great question. So we presented at the APA a really interesting study that Phil Greer, who's here, did, and he's actually going to present a couple of posters so you can talk to him. It turns out if you drink a moderate amount of alcohol, it markedly reduces your risk of gallstone pancreatitis, statistically reduces it. So secondly, the alcohol is more likely male who are at low risk of gallstones as well. So they typically don't occur simultaneously, but sometimes they certainly can. The other thing that's interesting, there's a paper that just came out of China where they went through and sequenced the DNA of people with mild and severe alcoholic pancreatitis, and they found out there was about a 45% genetic cause in patients that drank alcohol that was missed because they were diagnosed as alcoholic pancreatitis. But as Dr. Yadav showed, is only 3% of people, the heavy alcohol drinkers, get pancreatitis. And so you need some other factor to trigger it. And it turns out that these patients classified as alcoholic pancreatitis really have something else or they won't get pancreatitis. You ask about a gallstone and alcohol?
It's okay.
Okay, so the probability is it's low to have both. Yeah, it's not zero, it's low.
Thanks, Steve. Thanks, Dave. I'm going to ask a question about fluid management. James, what do you think? Because usually we have the evidence and then practice lags behind for a few years. What can you tell us a little bit about what would be your recommendation if you get an acute pancreatitis patient today? What's the rate and what's the type of IV fluid you would use before the guidelines change?
Yeah, it should have been an easy question, but it's getting to be a tougher question, right? Like a couple of years ago.
I could be hard on you. Yeah.
A couple of years ago, I would have said hammer him with some LR, right? You know, right off the bat. I think with the way the evidence is going, it shows it's much more nuanced. So it says you got to carefully assess them physically and to assess if what their volume status is, at least with clinical measures. And maybe when we get these better tools, we can say, I'd probably do a moderate rate now. I might give them a liter instead of 2 liters, and then I'd probably give them more in the range of 150 to 200 rather than 250 to 300, you know, based on kind of what we learned in Waterfall. I still am leaning towards LR, given the preponderance of evidence. You know, there's been about 5, at least single center RCTs that show some benefit in that direction, but it may be smoke, because we saw with ICU, there was a lot of benefit up front. Now it's a little bit more questionable. Certainly, there doesn't appear to be any harm though with LR plasma light versus NS. At least you don't have to replete the electrolytes much with LR. If you give NS, you have to keep giving a lot of potassium and things like that over day by day. So I don't think there's a whole lot of downsides. So I tend to start with LR, and then we'll see with Waterland whether it truly is a benefit.
James, very nice presentation of IV fluids. Of course, IV fluids are important, but I would also like you to comment into what else integrated with pancreatitis. There are multi-center trials that are going on. One of them is in the US, CARPO. One of them is in the UK, RAPID. What are your thoughts of how additional agents can be complementary to IV fluids?
I mean, that's a very good point, George. I think you're only going to get so far with fluids. I think you're kind of just sort of adjusting things a little bit to try to have a soft landing when you're going to crash anyway. I think you do need some type of agent to slow down the pancreatitis, at least in patients who have moderate and severe disease to really make an impact. Otherwise, I think, for mild, we could get them out a little sooner with the right fluids, maybe, or maybe moderate, we can make it a little bit not as quite a rough of an outcome. But I think that's the real key. And it is exciting. That's why Carpo is interesting and also in the UK as well.
Dr. Sirivardhana,
Hello.
you're nice.
Oh, sorry, you're having a chat amongst yourselves up there or what? Could I ask a question to my friend Ajit from Manchester about Pro-calcitonin? The control group, about 45% had antibiotics. The test group, about 65% had antibiotics. In your paper, you say you followed the IAP guidelines, 2012. The IAP guidelines say you should only use antibiotics in infected pancreatic necrosis. Yet you only had 5% of patients who had infected pancreatic necrosis. So what you should be doing really is educating people in your hospital not to use antibiotics, except according to the IAP guidelines. Or have I misinterpreted?
Hi, John. No, this is on. No, that's a great point. Thank you for that point. And actually, that's what the Dutch are doing now, because I think they think
I'm
that,
asking you,
sorry?
not what the Dutch are doing. I'm asking you. The Dutch are just following what we did years
Yes,
ago.
I agree. So actually, the Dutch aren't doing what we've been following. The Dutch are leading the way on this one. And the Dutch study, so I'll answer that in 2 points. First of all, we are educating our own residents about having more IAP, APA guideline compliant use of antibiotics. So thank you for that point. Where PCT measurement fits going forwards is, I think, as part of a package of interventions around antibiotic stewardship. And that's what Piano is currently looking at in Holland.
Thank you.
We thank all the speakers, and this concludes the session. Thank you.